Anna, good morning to you and welcome to today's webinar, a timely and important topic we're bringing back again, Medicare Basics, what you need to know, presented by Mr. Mark Trent of Medicare Supplement Services. My name is Jeff Stauffer, Community Relations Director with Elville and Associates, and I'll be moderating today's event. So how this will work today, if you're new to our webinars, if you are, welcome. We're glad you're here, and if you're a returning attendee, welcome back as always. So you as the attendee are currently in listen only mode. However, if and when you have questions, please note them in the questions panel on the right-hand portion of your screen, and we will take all questions at the end of this morning's presentation. This presentation does typically present lots of questions, so we will take them all at the end to allow for a good flowing presentation. Your questions really help the presentation and add value. They help others learn. So don't be shy in posing your questions at any time. For CFPs, CPAs, and various other professionals on today's webinar, you may receive 1.5 continuing education hours for attending. And per my attendance records requirements, please email me your board ID number. And for CFPs only, I also must have the last 4 digits of your social security number as soon as possible so I can submit your CE hours for approval. Everyone will also receive a post-webinar feedback email right after the presentation, and we do ask that you take just a couple minutes to fill out this simple survey to offer us your feedback about the presentation. We've received a lot of great feedback about our webinars and how we can improve them, and we read and value every comment. For example, we found this topic was often requested through our post-webinar feedback, so we made arrangements to make this presentation a reality. So here at Elville and Associates, through planning and elder law techniques, our attorneys work every day with families and their loved ones with ideals of client education, collaboration, and compassion in mind. We're always available for consultations to discuss your family's needs and look forward to being a resource to you in any way possible. So I have the pleasure of introducing today's presenter, Mr. Mark Trent of Medicare Supplement Services. Mark was the featured presenter at Elville and Associates 2017 and 2018 annual client events, and we've stayed in touch over the years, and he's been a valuable resource for many of our clients. Mark sold health insurance policies to self-employed people on the individual market for years. Later, he recognized how complicated Medicare was through his own family's experience and decided seniors needed help and guidance on how to not make costly mistakes. For 22 years, his business model has been to educate seniors about Medicare and how it works, find the best and most appropriate Medicare supplement plan for them at the lowest rate, and facilitate enrollment in a Medicare Part D prescription drug plan. For seniors, this means peace of mind regarding a very complicated and important subject. So Mark, thank you for being here today and offering this presentation. It's a very timely one, as open enrollment is just around the corner, and we appreciate your time. It's always good to see you, and I will turn it over to you.
Okay, well, thank you, Jeff, and thank you to Elville and Associates. For those of you, I guess there's a bunch of different reasons why people are here on this particular webinar. First of all, there are people that are approaching Medicare, like their initial enrollment period. There are people that are on Medicare right now, I'm sure. And there are people that are past the initial enrollment period, past 65, and still working and wanting to know, what do I do when I retire? There's all different kinds of scenarios here, folks. So there's no one way of doing everything. But what I'm going to do here, and you'll see this book right here, this is called Medicare You. Medicare You, in my opinion, is the least read book in America, because it's distributed every year to all seniors, and yet most of the time people are confused about everything it says. And it's because a lot of it's written in Greek. So let's try to get past the Greek and the Latin and try to get it into English about what this is all about. First, I'm going to talk about a little bit of history before we get into the nuts and bolts here. History-wise, the United States has never had universal health care, and this is the closest thing to it in the US. Back in 1935, we had Franklin Roosevelt introduce Social Security, and at the same time, he wanted to introduce health care for all. That was a part of the bill that was carved out. The conservatives from day one never wanted government to be involved in health care. So that didn't pass through Roosevelt, and then Truman was up next, and he tried it twice to get health care for all. That didn't work. The next one, of course, was Dwight Eisenhower, conservative, and he wasn't interested. And then there was Kennedy. Kennedy comes along and says, well, why don't we just amend this now to seniors, 65 and beyond? Now, you have to say to yourself, what was there before Medicare, before the 65-year-olds? The reality is, a lot of people just didn't have any health insurance at all. A lot of seniors just retired, and now they have, their golden years, but they have no access to health care other than pay for it yourself. And even back then, it was expensive. So next up, that was Johnson, who finally got this put through Congress. So 30 years after the first attempt, we finally got Medicare. And since that time, millions of Americans have been covered by Medicare. Currently, there's over 64 million Americans on Medicare. And it's growing still because we still have into Medicare to the tune of 10,000 a day. And it will continue this way for a few more years. So Medicare is kind of a big deal. Now, Medicare has continued to change, whereas there's original Medicare, that's called Medicare Parts A and B. Added to it, actually by Nixon, was the health insurance for people that are Medicare for people that are disabled below the age of 65. And then another huge change was in Medicare Part D, and this was under the George W. Bush administration with the introduction of prescription drug coverage, which, when you think about it, that was in 2006. What was there before that? The answer is nothing. So 2006, a major change occurred where we finally had access to more health insurance rather than prescription drug coverage, rather, and that was introduced then. And now, just recently, another major change occurred, and that was with the, what do they call it? The Inflation Reduction Act, which just was signed a couple of weeks ago. And for the first time, Medicare will for the first time negotiate for the prescriptions. The whole group hasn't been able to do that. It's all been done by private enterprise. So there's major changes still occurring. And Medicare continues to change. It evolves, basically. And it really is an attempt at universal health care. But still, it's focused on the seniors. Now, let's get into the nuts and bolts about the A, B, C, and the D. What is all this letters stuff that keeps going on here? A and B. First of all, Medicare Part A, you may not know this, but it's mandatory. You've been paying for Medicare Part A all your working life. Whether you like it or not, you have to have Medicare Part A. It's part of your FICA taxes. If you pay, that's if you pay, of course, your income tax. So Medicare Part A is the hospital, the hospice, and skilled nursing part. Think of it as inpatient coverages. And that book, Medicare You, it says in that book, there is no cost. Well, that's not true. You continue to pay for it all your working life. It's just that when you're allowed to have it at 65 and no additional cost. Then there is Medicare Part B as in boy. B is, let's just put it this way, it's kind of like outpatient coverages. If A is essentially inpatient coverages, which is say A is hospital, your hospice, and skilled nurse, but your outpatient coverages now is the stuff we all use. Now we're talking about doctor visits and testing and labs, emergency room, physical therapy, outpatient surgeries, chemotherapy treatments, durable medical equipment, basically anything you can think of that's not overnight. And at some point, at your discretion, you put the two together, A and B. Now you have then inpatient and outpatient coverages, and that is what's called original Medicare. Now, let me introduce you to what this thing is called CMS. You got to get this one right. The Centers for Medicare and Medicaid Services, that is Medicare. That's its real name. For those of you who live in the Baltimore area, CMS is right there in Baltimore. And it is, of course, where all the claims for the entire nation go, is to CMS over there in Baltimore. Medicare makes all the decisions about what is covered or not covered. And we'll get into how that happens. Now, so you've got original Medicare, and there's A, B, C, and there's a D. Now, we haven't got to C, we haven't got to D. We'll get to that later on. I guess you can figure out that D is drug. Now, let's move on to our next slide here. Parts A and B and premiums. Part A, we say, is free. Truth is, if somebody has never paid into the Social Security system, which is rare, or they don't have it, or they're not married, let's say, to someone that has. I actually met somebody who inherited a lot of money and never paid Social Security. That Part A alone would be like $473 a month if they didn't have to pay for it all along. And for you to qualify for Medicare Part A, you simply have to work 40 quarters. That means you have to work 10 years. If you don't work, let's say you're a mother that's bringing up the kids and the husband does all the work, or vice versa, whatever, then it's a situation of you would get your Medicare through the spouse because you took care of the kids and he worked. As long as he works more than 10 years, you got it, or she. Right. Now, Medicare Part B. Medicare Part B, outpatient services, is not free. Everybody pays for that. The standard level right now is $170.10, but we'll get into what's called means testing in a minute. The means testing means the government evaluates how much we make and how much you can afford. And when it comes to Medicare Part B. And then there's something, and that's what's called IRMAA, Income Related Monthly Adjustment Amount. So Medicare Part B, let's now get into how we connect these things, Medicare Part A and B. First, if you are on Social Security already before 65, you will get your Medicare card in the mail with Medicare Parts A and B automatically. Why? Because because Social Security is giving you money already. In other words, you're getting your Social Security check, so they know they can take that $170.10 out of the check automatically. That's why you get it in the mail automatically. If you don't want it, by the way, for some reason, like you have coverage through a spouse, then you can turn it around and say, I don't want Medicare Part B, just Part A. For those people that are say, self-employed and they're just approaching their Medicare, which let's say that it starts in November or something like that, you can sign up for Medicare online at at socialsecurity.gov. By the way, Medicare is a division of Social Security. So they're like the place to go, the boss basically is Social Security, which is a division of the Health and Human Services Department of the United States. So don't be surprised when you get in the mail something from the Health and Human Services Department of the United States. That's Medicare. So anyhow, you've got people that get the card automatically. There are people that sign up for the card automatically. And then there are people that later on who continue to work, who should sign up for at least Medicare Part A when they get near 65. We'll talk about that. But then they have to, if they leave the employer's group plan, then they have to sign up for Part B, connect B to A, and there's a procedure to do that. So there's all different kinds of ways of getting fully on Medicare. And yes, it can be confusing. That's why you talk to somebody like me. I don't charge for my services. I'll explain what you need to do. Now, so you've got Medicare, and let's talk about Part B first and what this means cost-wise. I'm going to go to the next slide here, and this is all about money. Income-related monthly adjustment amounts. The government does what's called a 2-year look back. They look back at what we did for our federal income taxes in this case, 2020. So here we are in 2022, and in 2020, they're looking at the bottom line of your federal income tax, and it's what's called the MAGI, the Modified Adjusted Gross Income. That means all your deductions are taken out on the bottom line, and plus any tax exempt interest. So if you're, let's say, filing individually and you're showing a modified adjusted gross income of less than $91,000, then you would pay $170.10. That's a standard level. That's what most people actually pay. If you're filing jointly, let's say with your spouse, and you're showing less than $182,000, then you're paying $170.10 as well. But if you are considered by the government to be a higher income earner based upon your income, then you can see it right there. Let's say you're filing jointly and you're between $182,000 but less than $228,000, then you would end up paying $238.10 a month for your Medicare Part B. The difference obviously is, well, I call it a tax, but they call it something else, but nevertheless, you're paying more money. Between $284 and $340, you're paying $442 and 30 cents, and it goes all the way up to somebody who's bringing down over 750 grand, and they'll be paying $578.30. So we are means tested. Now somebody's going to say out there, well, how long does that last? But if I'm making between $284 and $340, and so I'm really having to pay $442.30, what happens when I don't make that kind of money? Well, the reality is this. In 2023, the government will look back at what you did in 2021. So in other words, it adjusts up or down depending upon what your income was. Also, I'd like to point out, you can debate this with the Social Security system. Let's say you have something like a bonus, a $10,000 bonus to put you over the edge or something like that. It's a one-time thing, in other words. You can debate that with Social Security to see if you can get it back down to the regular rate. Or let's say you're somebody who has just retired. Yeah, you used to make that kind of money, but you won't anymore because you're now retired. In which case, then you can file a form with the Social Security Administration called the SSA 44 form, and then try to get that level back down. So we have Medicare Parts A and B, and we know that B is not free. Now, we also know that Medicare Parts A and B have inpatient and outpatient coverages. But what we need to talk about also was, what the heck is a supplement all about? Why are we talking about this? Isn't this 100% coverage? No, it's not. And I'm going to go to the next slide here. I think it's the next slide. Supplements. Medicare Medigap plans, or Medicare Supplements. There's like 11 of them, which you see right here on this little screen. The truth of the matter is only about 2 or 3 are actually sold, especially here in Maryland. And what they do is they fill gaps. Now let's talk about what the gaps are first, then we'll go back to those. Here are the gaps. So you got your Medicare Part A and you got your Medicare Part B. Let's say you don't have any supplement policy, any secondary policy. It's just A and B. Okay, well, you're looking at some real financial exposure. If you end up in the hospital, you would end up having to pay $1,556 deductible. That's not per year. That's per 60-day period. It works like this. Let's say somebody ends up in the hospital in March. They have to pay the $1,556. Then, let's say they go back into the hospital the same year, but now it's November, and it's been more than 60 days. So now you have to pay that deductible all over again. Of course, if you have something like a Medicare supplement plan, it would pay for it, not you. That's the idea. It fills the gaps. That's why they're called Medigap policies. Then there is, if you're in the hospital continuously from 61st day to the 90th day, then they start charging more money, $389 more per day. And if you're in the hospital up to 90 days, on the 91st day, they start charging $778 more per day. Those are gaps, and who wants to deal with that when you're retired? That's difficult. Now, Medicare Part B, it has its own deductible, $233, but just once a year. And then the part that can be devastating is the 80-20 part. For outpatient services, which is a lot of stuff, I mean, it could be like chemotherapy treatment. That's outpatient because you get your chemotherapy, let's say in a hospital, but you go home the same day. It's not overnight. Or you go to an outpatient facility. And let's say it's a $14,000 charge. Well, the government would pay 80% of it, but you want your Medicare supplement then to pay the other 20%. Nobody wants to deal with that. And then there's something called the excess charge, which is rarely done, but some states allow where if a doctor does not take what's called assignment, that's what Medicare pays him, he could ask for an additional 15%. But anyhow, that's pretty rarely done. But these are all known as gaps. Okay, so the government then says, all right, starting back in 1966, they came up with these things called Medicare Supplements. And there's so much confusion about how this whole thing works. All right, many of you, I guarantee you, have heard of Medicare Plan G, or Medicare Plan F, or Medicare Plan N. What's the difference? Well, what it comes down to is the degree of coverage, meaning how many gaps will it fill? And so let's say you've got something like Plan G. G is the most popular plan in America. And you go back to that little slide right here, Medicare Plan G on Part A would pay for the $1,556, the $389, the $778, no matter how many times you're in the hospital. Plan G would pay the 20% and the excess charge. What Plan G would not pay for would be the $233 deductible on outpatient services. Now, that's a pretty easy one to understand. You pay nothing, not even a co-payment, when it comes to Plan G, with the exception of this once a year deductible on outpatient services. And when you think about $233, that isn't a whole lot of money these days when it comes to healthcare. And the other plans are all like that, meaning they all fill the gaps in various ways. Plan F, which if you're new to Medicare or about to be new to Medicare, you cannot get. It was discontinued for you younger people in 2020. Plan F was the Cadillac of all plans. It fills all the gaps, including the 233. You pay nothing with that particular plan, except of course the premium. And so that was the best plan of all. And that was extremely popular, Plan F, from 2010 to 2020. But the government decided, people are going to the doctors too much because they have no skin in the game. They don't have to worry about paying something when they go to the doctors. So they decided that we have to cut that out. We have to shut that one down and then make Plan G the big Cadillac of the bunch. So Plan F, if you are on Medicare prior to 2020, yes, you can still be on Plan F, or you can still get a Plan F. If you've been on Medicare after 2020, you can't get it, period. That's how it works. The other plans, like GHD, that's a high deductible plan. That means after you've met your initial deductible of $2,480, then it kicks in. Is the premium lower? Sure, of course, because you're paying out of your pocket $2,480 first before it kicks in and does anything. So these things are all, and the plans that I've highlighted here, A, G, GHD, N, and then there's an F and F, high deductible. But the reality is what everybody really cares to have really is G and N. By far the most popular plans, especially here in the state of Maryland. Now, about how the money stuff works when it comes to supplemental policies. Let's say you're 6 months away from becoming eligible for Medicare at 65. A trickle begins of stuff coming your way from insurance companies and from the government, basically reminding you that you could end up getting a Medicare supplement if you go on Medicare. And it becomes a flood the closer it gets. And they're all going to be, and all the insurance carriers out there, carriers you've certainly heard of, Care First, United Healthcare, Aetna, Cigna, Mutual of Omaha, et cetera, et cetera, et cetera. They're all screaming at you saying, hey, my plan G is the best. It's not. G is G, meaning the government, the federal government, Medicare, makes all the supplement plans, not the insurance companies. The insurance companies are contracted to be able to sell them, and the government allows it. And so let's say somebody gets a Plan G and Aunt Mabel says, hey, you want to have Plan G. And I got my Plan G from a company called Standard Life and Accident, and it's a great plan. You ought to get it from Standard Life and Accident. There's nothing wrong with that. G is G. But Aunt Mabel may not understand that Standard Life and Accident may not have the best price for the exact same coverage. Or on the other hand, there might be a company over here called Aetna selling the exact same thing, significantly less money. To give you an idea, I don't know if you guys can see this or not, but I have a little folder here of what's called rate sheets. This is what you consumers can't get. This is what insurance company people get. So to give you an idea, even though you may be trying to go online to try to figure this out, good luck. Let's say you wanted a plan from Cigna. Aunt Mabel says, get Cigna Plan G. Cigna's trying to sell it to a female 65 in the state of Maryland for $183.10. This is Aetna. They're trying to sell you the exact same thing for $144.94. Is there any difference other than 40 bucks? No. This is a company called Mutual of Omaha. They're selling that same plan for $141.63, but there's one little kicker there too. If you're simply living with somebody 60 years of age or older under the same roof for more than 12 months, then you qualify for a household discount, in which case then they can get that exact same plan for $124.63. Which would you buy? 183 because Aunt Mabel says Cigna's the best when it's not? Or would you get Mutual of Omaha because they're selling Plan G for less? Is there any difference? No, not at all. Is one company going to zoom up the price faster than any other? No, not at all. It's all controlled by the state of Maryland anyway. They can't just do that. So basically it comes down to this, and this is my bailiwick. And that is, if you want to find out who's got the best rates, you talk to someone like myself who is appointed to all these different companies and who's ever selling you the plan you prefer to have. Whether you've identified you want plan N, great. Now, who's got the best deal? Who's got the best rate? Because it's not about the coverage, it's about the price. Now, here's another one other little big thing about what most people don't understand about Medicare. You're used to an employer's group plan. The vast majority of you have been on an employer's group plan. You're used to the boss being whoever that insurance carrier is. Let's say the carrier is Care First, Blue Cross Blue Shield. You're used to believing that if there is any kind of a claim, it's going to a company called Blue Cross, or rather Care First, because it's a Maryland franchise, and they adjudicate the claim. Now, Medicare, you may be getting, it's not Care First, you're first, but your health supplement policy, secondary policy from Care First insurance company is Medicare. Something just came up on my screen here, excuse that. They make all the decisions about what's covered or not covered. So when you file a claim, let's say you go to a doctor and you get an MRI. The MRI, let's say, costs $1,000. That claim goes to CMS, goes to Medicare, not to your supplement company. It says, okay, that's legit, that's medically necessary. Medicare then pays its 80% because that's an outpatient facility thing. The other 20% then is picked up by your supplement, but it is Medicare who communicates with whoever the supplement company is. And it says, you now fill in the gap according to the contract. So who's controlling this? Who's running the table here? Medicare is, CMS is, it's the boss. Now, if Medicare claims covers a claim, then your supplement policy will also cover the claim. If Medicare does not cover a claim, if it says, sorry, we're not paying for whatever that is, then your supplement company will do nothing. It simply follows suit. If Medicare pays, they pay. Medicare doesn't pay, they don't pay. That's how the system has always worked. And yet, let's say somebody's on that Care First, they're thinking, well, why can't Care First pay for this? Because it's Medicare that makes the decision, not Care First. They are just contracted to fill in the gap. So think of Medicare supplement companies, secondary plans, as just gap fillers. But they're not they are not the decider. They're not the ones that make the decision about what's covered or not covered. Medicare is. Oh, by the way, if you want to know a little bit more about what Medicare covers, just get the app online. You can go to Apple or Android and just pull down the Medicare app. There's a lot of information in there anybody should look at. Now, let's move forward to what everybody's favorite is, which is drugs. All right. Prior to 2006, there was no prescription drug coverage for seniors. In 2003, they had a knockdown, drag-out fight basically in Congress to introduce, and I'm not trying to get political here, but here's reality. It was a Congress that was, of course, George Bush was a Republican. They had the House and they had the Senate. And basically, they did not want Medicare and 64 million people to negotiate the rates for Medicare for prescription drug plans, or prescription drugs themselves. So what they ended up doing was leaving it in, of course, private enterprise, which is to say that you've got prescription drug companies now, instead of CMS, Medicare negotiating with the pharmaceutical industry, it's the prescription drug companies and the prescription drug plans that negotiate with the pharmaceutical industry. And because of this little move, they have to negotiate every year. We're about to come upon this open enrollment season, Medicare Part D open enrollment season. All this begins October 15th through December 7th. What is happening here is that your plan, or the one that you think you want to get into, has negotiated the rates of their cost of the prescription drugs through the pharmaceutical companies, and every one of these prescription drug plans is different. There is no such thing as one size fits all. It doesn't exist. What you do is you go to the one and only place you can go, which is medicare.gov. If there's a website you guys want to get familiar with, go to medicare.gov. You can enter into that database precisely the medications you're taking. What the database is going to do then is it's going to take into summary all of the medications you take, and it's going to go into this database to find out what particular prescription drug plan has the best overall buy in the accumulation of Medicare medications that you actually take. And so it's been negotiated. You get in there to a plan that seems to have the best price on the medications, and the overall effect is this. The bottom line is, it's not about the premium of the prescription drug plan. You want a plan so that when I go get my medications at the drugstore counter, I pay as little as possible for the medications. So it's really about the cost of the medications at the drugstore counter. That's what it's all about. And only that database can tell you how to find the right plan. Now, this is going to be surprising to some people, but let me just say this. Don't buy a prescription drug plan from an agent. You're going to get all kinds of crap in the mail that says, go ahead and please buy this from me. The reason is the prescription drug plans, all of the agents who are appointed to sell, let's say, a Humana prescription drug plan, they're getting a commission to sell it. But that doesn't mean that that's the right plan for you, because it's based upon the medications. So the only place to go to get a really reliable idea about what's got the best deal for the accumulation of medications you take is Medicare.gov. It's the only place to go. So so during the open enrollment period, and those of you who are counting open enrollment now, you're going to want to go there to CMS, to Medicare first, and I'll explain that in a minute about how you should do that. But yes, our Medicare Part D plans are complicated, and it's all about the medications. It's not about the name of the company, the prescription drug company. It's all about the meds. Now, about Medicare Part D, I'm going to get to this part right here. Remember Irma? We were talking about Medicare Part B as in boy, and how we are evaluated by the government. Well, Medicare Parts B and Part D both come through the government. And those that come through the government means you can be evaluated, and Irma kicks in here also with Medicare Part D. So you'll look at this thing right here. Let's say you file jointly And let's say you're somebody making between $340,000 and but less than $750,000. But let's say your prescription drug program is very minimal, meaning you take just cheap generic medications. The least expensive prescription drug plan out there is only $7.10 because you take cheap generics. But here's the problem though. Because you are a higher income earner, you would also have to pay a surcharge. That's what I was thinking of earlier, and not a tax, but a surcharge of $71.30 to the government. So in reality, yeah, it's a $7.10 plan, but I'm paying $71.30 on top of that just to have it. Now, some of you are probably saying, well, wait a minute. I barely take medications. What if I don't want a prescription drug plan? Well, guess what? It's voluntary. You do not have to have a prescription drug plan at all if you do not want one. But there's a little hiccup to that one. Let's say your eligibility for Medicare starts November of this year. And they all start, by the way, at the beginning of a month, unless your birthday is the beginning of the month, in which case you're eligible for Medicare the month prior. But anyhow, let's say your birthday is November 13th, but you're eligible for Medicare starting November 1. You got your Medicare card, you're all lined up, you're all ready to go, but you don't want a Medicare Part D drug plan. You just blow it off. I don't want it. Okay. If you go more than 63 days without getting a Medicare Part D drug plan, so let's say now we've gone through November, we've gone through December with nothing, and now let's say it's February. You haven't got a drug plan, and now you find out some sort of health issue comes along, and suddenly you need something like Eliquis, which is an expensive brand name medication. You then go, well, I want to sign up for one now. Well, you can't get one. You're barred from getting a prescription drug plan. And on top of that, you're also going to get a penalty. Now, you can get your Medicare Part D, but not until the next open enrollment, which would say be fall of 2023. You sign up for your prescription drug plan then, and your new policy begins at the beginning of 2024. But you're also going to get a penalty. The penalty is 1% per month for every month you could have had it. So that meant you didn't have it in November, you didn't have it in December of 2022, you didn't have it for the entire year of 2023, so that's 14 months. Now you're going to be paying on top of, and this is actually not exactly right because there's 1% of a national average, but let's say you're going to be paying somewhere in the range of about 12 to 14% more on top of that premium for life. It never goes away. The government says you don't have to have a prescription drug plan, but if you don't get one when we tell you to, you're going to get your teeth kicked in later on. So the reality is, yes, it can end up costing you a lot more money than you thought. All right, now, so Medicare Part D, it is voluntary, but the vast majority of people do get a prescription drug plan because they're quite useful. Now, having said that also about prescription drug plans, let me mention this real quick. Nobody says you have to use your Medicare Part D drug plan if you can find the medication someplace else cheaper. For instance, GoodRx or the Canadian Pharmacy. These are all legit businesses. And let's say you're getting, if you go through Medicare Part D on your personal drug plan, and you find that they're charging $150 for this medication, and yet you can get the exact same thing through GoodRx for $50, nothing's stopping you. You can. So there's nothing wrong with checking outside the system as well. Most of the time, Medicare Part D will do a good job, but it really depends. Sometimes, well, I'll give you a perfect example. My wife had to get some sort of a cream one time, and it was going to cost her on her Medicare Part D drug plan. And this was an unusual thing. It was not normal. It was not her normal maintenance medications, and it would have cost her $143. And then I say to my wife, "Oh, honey, why don't you check out the GoodRx card?" And there they said, "Oh, you can get the exact same thing now for $43. That's a good deal, $100 less." And then by sheer coincidence, it turns out that medication was on sale, believe it or not, that week. So she got it for $23. So the reality is there's nothing wrong with going outside of the system if you want to check and see if you get a possible better rate. I mean, for the plan. Now, let's go into a little greater depth about a little bit about the history of Medicare Part D here. And then we'll talk about open enrollment here. First of all, Medicare Part D was shepherded through the Congress by a guy named Billy Townsend. You can look this up online. Billy was a representative from Louisiana, and he got it through Congress basically. And what ended up happening then is, and of course the Democrats were not allowed to negotiate because they wanted the pharmaceutical industry to basically have a really good deal here, which they got. Billy ended up being, after he left Congress after the bill got passed, and he ended up being the head of Big Pharma. Well, Big Pharma in terms of drug, what do you call those guys? Lobbyists. Anyhow, so yeah, there's a little bit of politics always involved in this, but not having anything at all was far, far better than what we had in the past, which was nothing. And that all started in 2003. That's when it really began to be heating up here. Now we have a situation where, because of the latest bill, and yes, we are talking about the Democrats are trying to get the ability to negotiate the cost of prescription drug plans. Now on this new job, Inflation Reduction Act, it works like this. On your prescription drug plans right now, for those of you on Medicare Part D, you could very well be out of pocket as much as $7,000 because there are different stages, which we'll talk about here in a second. But because of this Inflation Reduction Act, the most you'll be able to pay, and most you'll pay out of pocket is up to $2,000 when this thing kicks in. Okay, and the $2,000 out of pocket provision only goes into effect starting in 2025. So we got to wait a little while. The new bill also allows Medicare to negotiate the prices of 10 drugs. That's it. For now, it's just 10 drugs. That starts in 2026. Then it increases to 15 drugs in 2027 and 28, and then up to 20 drugs in 2029. So basically, when it comes to the drug plans, not a whole lot is really changing until 2025. How is it really going to work? We don't know. I mean, this just happened. This was like a couple of weeks ago, but it's a good start. I mean, it's on the way to getting greater, but lower rates for the prescription medication. And I'm sure everybody knows our prescription drug program is pretty darn pricey, or the price of medication just in general is incredibly pricey. All right, now let's get into this thing called open enrollment. When you're starting on Medicare, you have your initial enrollment period. That means that's the government's way of saying, come on in. Open enrollment means come on in. No questions asked about your health or anything like that. You are eligible. You've got it. Now, when it comes to Medicare Part D drugs, they change. You change. Human beings must get different kind of medications as time goes by. And so the government wisely did build in this situation called open enrollment. It's always between October 15th and December 7th. And the best way to do this is to call up, believe it or not, Medicare itself. Now you can go online to medicare.gov and do it yourself. Only it's a complicated website. So what I always tell my clients is the following. Number one, you need to change your prescription drug plan every year. Don't anticipate that the plan you pick up, let's say in 2022, and works fine for the year 2022 will be just as good in 2023. It won't be. You need to review to see if there's a better plan for 2022. The assumption is that the negotiation that I mentioned before that goes on for the medications that they're going to represent in 2022 will be with the same things that they get in 2023, and that's wrong. So suddenly a medication that was cheap in 2022 suddenly becomes a whole lot more expensive in 2023, and that's because you did nothing. You didn't look at during the open enrollment period to see if there was a better plan. Now, what's the easy way to do this? Call Up Medicare. The open enrollment, as I said, always between October 15th and December 7th, and the new plans always begin January 1. And you'll notice here, I say here, don't sweat. You got 7 weeks. All hell breaks loose at the beginning of October. People are calling in the Medicare day and night, trying to get this done immediately. You got 7 weeks. Just call, in my opinion, you should just call somewhere between the first, second, or third week of November and get it done then, because your new plans don't begin till January 1 anyway. And by that time, the agents that work for the government are well seasoned, shall we say, because they're going to be attacked, I guarantee it, starting October 15th. Now, calling Up Medicare, it's open 24/7. Right now you could call, or 10 o'clock tonight you could call Medicare. It's open 24/7. And everybody seems to think it's only open from 9 to 5 because it's a government agency. They're wrong. It's open 24/7, especially during the open enrollment period. Calling between 9 and 5 is crazy. Wait until like 8 o'clock at night after the West Coast is shut down. It's a whole lot easier. Or maybe like some of my clients at 4 o'clock in the morning because they don't sleep. You know, no problem. You get right on through. When you do talk to these guys at Medicare, be very specific about your drugs. I can't overemphasize that. Meaning, if you're really taking Lipitor, then it's Lipitor. But if what you're really taking is the generic version of Lipitor, which is atorvastatin, tell them it's atorvastatin. And what's the milligram? What's the dosage? Do I take a pill a day or 2 pills a day or whatever it is? Be very, very specific. And I have had situations where somebody says to me one time on the phone, I take 450 milligrams of X medication, whatever it was. When I put that into the database for Medicare.gov for that client, it came up with an incredibly expensive out of pocket for that medication. It was ridiculously expensive, like thousands of dollars. And then she reveals to me that, oh, well, no, I take actually 3 150 milligram pills a day. That's what you need to tell them. It's 3 150 milligram pills, not 1 450, or you'll screw yourself up. You need to have your Medicare card in front of you. We are nothing without our Medicare numbers. Our Medicare numbers now are specific to you and only you. So the only way to identify who you are is with the Medicare number on your card. Telephone number for Medicare, by the way, is right on the back of your Medicare card. And then you go to Medicare.gov yourself. You can do it yourself, or you can also, if you're not into any of that stuff, some people just don't even use the computer, well, then you can make an appointment with something like the Department of Aging, or you can basically, there are other services like a senior center that might do this sort of thing for you. So basically, it's all the same thing. They're all going to the same place, Medicare.gov. It's the one and only place to go. But I always give these tips to my clients. Now, about Medicare and how it's broken down. Where did I put that stuff? Okay. There are really 4, when it comes to Medicare Part D drug plans, there are really 4 stages for the Part D plans. Stage 1 is a deductible. If you have a tier 1 or a tier 2 medication, you are not subject to any deductible. Even though your plan may have a $480 deductible, which is what's allowed by Medicare right now. Most of the plans have a $480 deductible. If you're taking something like lisinopril, which is like a tier 1 medication, it doesn't matter because you won't have to deal with that deductible. On the other hand, if you're taking a medication like Eliquis, a brand name product, which is like a tier 3 or 4, then you have to defeat the deductible first. So that's stage 1. Stage 2 is basically where did that sucker go? Here we go. Stage 2 is where you'll stay in that stage until the amount of your year-to-date total drug cost reaches $4,430. What does that mean? It means that they pay a percentage and you pay a percentage. And the drug program means the prescription drug people, pay more than you considerably, like they're paying like 75% and you pay like 25%. But when you hit this maximum that you ended up paying $4,430 over the year, then you hit the gap, which is called the donut hole. And now they're paying very little and you're paying a lot until you get to this $7,000.50 max out of pocket. And then finally you get into the catastrophic stage 4 level where they pay like 95% of everything and you pay maybe 5%. Now, the truth of the matter is most people don't get to those two last levels. The vast majority of people are in stage 1 or 2. But everybody gets confused by it because it is a confusing system, the way it's set up. And that $7,000 that I just mentioned here, with starting in 2025, somehow that's going to be reduced to $2,000, and that's the end of it. Now, how's that going to work? I don't know. We're all going to find out at the same time, I guess. Now, let's talk about something totally different. Medicare Part C. I mentioned Medicare Part D. Medicare Part C and Medicare Part D, when it comes to open enrollment, are the only two things to change. And this is going to be shocking to somebody who's already got a Medicare Medigap plan. You can change your Medicare Medigap plan any time of the year. Open enrollment is only for Medicare Part C and Part D. This is your shot if you want to change those. Now, what is Medicare Part C? Medicare Part C is what's known as Advantage plans. Medicare Part C also were plans developed and really changed in 2006 with the drug program. And Medicare Part C plans were developed by the government as a way of keeping the costs down to the government and putting more of the responsibility on the shoulders of the senior. They are very convenient in one aspect. They are cheap. The vast majority of them have very low premiums. In fact, some plans literally have no premium at all, which ought to tell you something. If you've been on the earth as long as I have, something for nothing is usually not a good thing. But you have these Advantage plans. Advantage premiums are quite low. Out of pocket, meaning things like your deductibles and co-payments, are relatively low. But what they really don't tell you is, because it is private enterprise now. In other words, it's not made by the government. The Advantage plans have to cover the basic stuff that Medicare covers, but they also get to make the decisions about certain things that are covered or not covered. And I'll give you an example of this. Somebody calls me up one time on an Advantage plan in Pennsylvania called the Geisinger plan, has no premium, and his next door neighbor is one of my clients who has a Medicare Medigap plan. The guy that was my client in Pennsylvania is on Plan G. He ends up having a heart problem, a few $100,000, but it was all paid for by Medicare and the Plan G. But this guy has his zero cost Advantage plan, and now he's got problems with his legs. Out of the blue, he's got something going on with his legs, and his doctor wants him to get a test. He gets the test, and Geisinger says, we're not paying for that. And it was $1,500 out of his pocket. And then, since it was undetermined still after that one test as to what was wrong, they ended up having to get another test, and that cost $2,500. So this guy's freaking out. So he talks to his neighbor, and his neighbor says, talk to me. And I can't help this guy, because what he doesn't understand, and most people will not understand, is that when you're on something like an Advantage plan, two things. One, you can't get off of it until the end of the year, no matter what. Number two, the Advantage plans are not designed so that you can move from one Advantage plan back to a Medicare Medigap plan. To do that, you have to prove insurability. And this guy didn't have insurability because nobody knew what was wrong with him. So he was stuck with it, and he will be stuck with Advantage plans for the rest of his life. So Advantage plans are not necessarily easy to move out of once you're in them. Now, Medicare Advantage plans also have, especially here in Maryland, and this is not all throughout the entire country, but here in Maryland, these plans have a $7,550 max out of pocket. What does that mean? It means, let's say somebody, God forbid, comes down with cancer and they have a $14,000 chemo treatment. That means they're going to have the chemotherapy treatment. 80% of that will be paid by the government, will be paid by Medicare. The other 20%, though, is your problem until you have reached the max out of pocket of $7,550. Now, for those of you who watch TV, and you can't miss this, there's all kinds of advertising that's going to get way more severe starting October 1. It's trying to push Advantage plans, and I guarantee you they never mention the maximum out of pocket. This is the thing about Medicare Advantage plans, where they have their point. They are better than nothing. What I don't like personally is the fact that when somebody gets sick, and everybody eventually does get sick, then they may be out of a whole lot of money when they least need to be out of it in their lives. That's why I'm not a big fan of Advantage plans and never will be. But they today, like I said, especially, there's a lot to do also with what state you're in. For now, there's lots of Advantage plans down in Florida, which are far superior to what we have here in Maryland. Now, why that is and how they do it down there, exactly, I don't know. But when it comes to Advantage plans here in Maryland, they're not so good. They're not so great, but they are going to be advertised to you, and you'll see personalities like Joe Namath telling you they're the best thing since sliced cheese. Well, not necessarily. All right, now, this is what was in the latest act that just occurred a couple weeks ago. Inflation Reduction Act, and that was about the prescription drug plans and what we can do there. They also mentioned here, though, about Medicare Part B enrollment changes. For those of you that are intending to go on Medicare, you don't have an employer's group plan, or you want to retire at 65, it's a relatively simple thing to do. If you're at least 3 months in advance of your birth month, and all you need to do is go to socialsecurity.gov and sign up right there. It's a relatively easy thing to do. For those of you that are and want to go to let's say you've been on Medicare, but you only have Medicare Part A and you've never had Part B. Now that's pretty rare. I actually met somebody one time that was 70 years old and had nothing more than Medicare Part A, period. And he wanted to get now Medicare Part B. And I asked him why he never got the outpatient services, and he says, because I never go to the doctors. He hadn't been to the doctor in like 34 years. And he wasn't kidding. So now he wanted to get Medicare Part B, but because the initial enrollment period for Medicare was a long time ago, he has to wait to get to a special election period to sign up for Medicare Part B, which is only between January 1 and March 31. So in that 3-month period, he could sign up then to get Medicare Part B. But two things, they wouldn't give it to him until July. Why he would have to wait until July never made any sense to me. But also, he'd get a penalty. If this individual had no other coverage, like nothing through an employer, and he had just Medicare Part A and nothing else, then he was going to get a 10% rate up per year on his Medicare Part B, which means he was going to get a 50% rate up for his Part B because he never signed up for Part B ever. And he was not going to be happy. But what did this current Inflation Reduction Act do? Well, first of all, the special election period, you don't have to wait until July now at all. If you sign up for Medicare Part B, let's say in January of that special election period, then you'll get it the next month. If you sign up, let's say in March, then you'll get it the next month. There's none of this waiting. There's none of this silly delay thing. That's been eliminated altogether, which I think is a great idea. It never made any sense to me to begin with. So that's been changed as well. So Medicare, again, continues to change. Now, let me see here. What have I forgotten here? Nope. Sorry, guys, I'm just reviewing what I should have been doing here. I think it may be time for some questions. Oh, one thing. This is important also. I said earlier that you can change a Medicare supplement policy any time of the year. There's a caveat. When you start your Medicare Part B, whenever you start it, you also start at that time an open enrollment, a health open enrollment. The health open enrollment basically means, come on in, I cannot ask questions for the existing conditions. So let's say somebody has been on Medicare now for a couple of years, and let's say their plan G has gone up in premium, and they want to do some shopping. They call me up, somebody calls me up and says, hey, what's the cheapest premium you have for your Medicare plan Part G, Plan G? All right, so I find it, and let's say that if this person could do it, they can get like $50 less in premium for the exact same thing, and which is great, except that I have to ask questions now about pre-existing health conditions. If it's been more than 6 months, I have to ask about their health. If they are considered relatively low risk, and which is difficult to define, but relatively low risk basically means they have problems. I mean, we're talking people 65 and older. Who doesn't have some sort of pre-existing condition? Sure, hypertension, high cholesterol, acid reflux, maybe they're type 2 diabetes, but for the vast majority of carriers don't care. That's fine. On the other hand, if somebody's got heart disease, cancer, Parkinson's disease, bad stuff, in other words, then all companies, no matter who they are, folks, are going to say, sorry, your risk is too high, you don't qualify, have a nice day. In other words, you could be declined coverage. So if you want to move, you most certainly can. But at some point, everybody, sooner or later, gets stuck. Now, have I changed people as old as 80 or more than 80 years old? I have. I've had some people in their early 80s, taking maybe 5 different medications, but still what they were taking is not enough risk to an insurance carrier. They'll take them no problem. On the other hand, sometimes we get surprised when, say, somebody has diabetes, type 2 diabetes, but also takes a medication for hypertension, high blood pressure. So the combination of the two makes that person a high risk. And you're saying, why? What's the big deal? Well, the big deal is if this person decided to stop taking that prescription medication for hypertension, then that could lead to major kidney issues because of the diabetes. In which case, then none of the insurance carriers would insure that person because of the risk potential. And that's what it's all about, risk potential. So when it comes to making a change, lots and lots and lots of people change. I change people all the time from one company to another. But we got to go through the battery of asking questions about pre-existing conditions and what kind of medications they take and that sort of thing. And then they go through the underwriting process. That means they check. How they check, by the way, in terms of somebody's pre-existing conditions is usually databases. There's never something like a physical. It's just more databases than anything else. And it's all computers talking to computers. So lots and lots of people can change, and it's entirely in their best interest. If they can do that, if they can go from one company to another and save money, there's nothing wrong with it. All right, so now where are we now here, Jeff? How much time we got left here? Okay, we're doing pretty good.
Yeah, thanks, Mark. Yeah, we're at 11:05, so We were going to go to 11:15, but I did mention to our those registered that we would probably go a little bit over to answer some questions. So, please, I know we have a number of questions here. Go as long as your time allows. And also, if you could please let people know how they can get in touch with you, Mark, that'd be great. And I'll note that in my follow-up email to everybody as well, which will come out by first thing tomorrow.
The first question here, well, the one I'm looking at the moment, rather. Gentleman says, I have Aetna with Medicare A and B coverage. How do I also enroll for a Medicare Plan G? Now, it sounds to me like you've already got a Medicare supplement as it is. And I've been retired for 15 years and have been taking A and B since then. Can I enroll in Medigap Plan F? Well, I assume you've got some kind of Medicare plan because you've got Aetna. Unless you're talking about Aetna for your prescription drug program, in which case that's Medicare Part D and has nothing to do with A and B. If you have A and B and you want to get a Medigap plan, then certainly give me a call, and if you can health qualify, I can certainly get you to that. And I suspect that yes, you are probably eligible for Medicare Plan F, because it sounds like you've been on Medicare prior to 2020, in which case then sure, you can get Plan F as long as you can health qualify. But again, it all comes down to your health. Now, for those of you that might want to write this down, my telephone number, my business telephone number, 301-730-8229. 301-730-8229. Now, let's go back to some of these other ones here now. Oh, good Lord. Someone's looking for his 83-year-old mother in long-term care with dementia. Oh boy, who will be transferring to Medicaid. Can you touch on how her Medicare will be affected by that? Well, Medicare will stay where it is. It's not going to. Medicare itself won't change. And Medicaid would essentially pay for her Medicare Part B. So she'll probably have less of a burden on her Medicare Part B. That'll probably go away because Medicaid will pay for it. Medicaid would also probably pay for her prescription medication. So that's probably two good things for her. She also has an Advantage plan. Well, I think your Advantage plan will become kind of irrelevant when Medicaid kicks in. And her out-of-pocket is going to go down dramatically because of Medicaid. So that's actually a good thing for her situation. Okay, my daughter, oh my heavens, is Down syndrome. And she works part-time. I understand that after 2 years, oh yeah, Medicare, anybody can be on Medicare at any age, even if they're obviously below 65. If I had somebody I signed up one time who was 34 years old, thought he had the flu, and actually what was happening was his liver was dying. And he ended up getting a liver transplant, but he also got Medicare because he has to go through 2 years before he's eligible to get Medicare because he has to be considered disabled. And then here in the state of Maryland, as long as he do it within the first 6 months, I could get him what's called Medicare Plan A. Now, Plan A is really pretty much reserved for the disabled. It has more holes in it than, say, a Plan G, but it's way, way better than the alternative, which means it's got more out-of-pocket involved in it. The biggest issue here in the state of Maryland, though, with like a Plan A is, for reasons I never understood also, is that the premiums on Plan A are significantly higher. And by the way, when I say Plan A, I don't mean Part A. Plan A is significantly higher because they know it's going to be for disabled people, and obviously they're spending a lot of money. So you can get that for sure here in Maryland, though, as long as you're within that first 6 months after you've got your Part B set up. And yes, you may be able to get Medicaid. Now that would have to be to get Medicaid, you're going to have to talk to the state. Medicaid is funded by the federal government and the state, but the state runs it. So if you want to have to get somebody on Medicaid, you're going to have to talk to the state about whether or not this person has a low enough income to be able to qualify. But you have to talk to the state for that one. I have Blue Cross Blue Shield federal program. They told us you don't need Medicare Part D because Medicare as a primary insurance. Yeah, basically what you're talking about is you have an employer's group plan that is a retirement plan. Not everybody has that nice little thing available to them. And yeah, Medicare becomes, A and B becomes your primary, but you can continue to use your employer plan, and it pays then for your Part D, so it just incorporates it. And you get a deal basically through your past employer. So man, it's a nice deal. Husband has Medicare, has free Part A, and his wife does not have 40 working hours. Yeah, should his wife pay the cost of Part A? Well, does the husband, has the husband worked more than 40 quarters? If he has, then you qualify through him. For instance, my mother never worked. She just raised the kids, and dad worked, and she got all the benefits she could possibly get through him. And you should be able to as well, as long as he's worth more than 40 quarters and you're married. How will RMDs, or withdrawals from taxable income, impact IRMAA? I'm not sure what an RMD is, guy. In other words, I'm not a financial services guy.
Required minimum distribution, Mark.
Oh, right. I still understand. I don't know. That's not my bailiwick. I don't really know. Talk to your CPA. And yeah, I assume it could, but I don't know how that breaks down. What is it? What is the money in the table meaning? What is the money? If my husband and wife pay joint tax, should they pay her own Medicare A, B, or do they pay together? Medicare is as individual as it gets. That means it's a household income. Then in this case, you would be paying for your Medicare Part B. Let's say you're the female and you're the guy. You're both going to be paying for your Medicare Part Bs. So it's not together. In other words, there's no such thing as a family plan. I think that's what you're kind of looking at. But no, that's not the case. They are completely individual. So you'd pay $170 and $10, and he'd pay $170 and $10, plus to get the Medicare supplement, plus getting the Medicare Part D drug plan. So everything is basically separate. But if you get a Medicare supplement through the same carrier, you may very well be able to get a household discount on the supplement plan, but not on the Medicare part. That's the government. If an employee can carry his or her medical plan into retirement, should they consider still applying for Medicare Part B? Yes, because Medicare Part B is going to be the primary. You're going to Medicare A and B will be the primary insurance company, but you can maintain though the employer plan if you prefer. Usually that's the most expensive way to go. You can, but it depends on what your employer is doing for you. But usually that's kind of expensive because usually it's a situation where it's just cheaper to get your Part B and then also get a supplement policy, which would be cheaper than the employer group plan and the Part D. On the other hand, you can still go this way if you want to. I am retired from the government, employed with insurance through, government and GEHA. I assume that I should keep you should keep what you got through the government, because there's a lot of government workers here who usually get retirement plans if they've worked long enough, get some really great benefits. And they aren't like the rest of us who have been, like, say, independent, working for somebody else, or had their own private business like I do. In which case, then you got to go my way. And let's put it this way. If you don't have a retirement plan through an employer's group, then your next stop after you retire is Medicare, Medicare, or Medicare. That's it. There isn't anything else. Those people that have worked for something like the government, the federal government, they have a completely different deal. Okay. Same thing with the medications. It would just stay there with that plan. How do we not go through Part D if cheaper on GoodRx? Do I just tell my pharmacist not to bill Part D, use GoodRx? No, just do it at the pharmacy. Just whip out your you've got your Medicare card there already. Your Medicare Part D card is with them. It's in the system automatically. But then you've got your own card to the left here. Let's say you've got your little GoodRx card, and say, which of these is the better deal? With my Part D plan, how much is it going to cost? Oh, well, here's my GoodRx card. Is it cheaper? And if it is, use that. That's all. So it's right there at the drugstore counter. Does Medicare Plan A, B, D could filing so that a couple only pays one premium for both wife and husband? No, guys, you're not getting away from that. Each one of you is going to be paying your own Part B premium. There seems to be a trend here. Yeah, my former employer reimburses part of my supplement premium every month. Should I still shop around for Part D every year? Yes, you should, because most human beings change their medication over time anyway, and then the plan you have right now may not be a good deal for you in 2023. If you want to pay more money out of pocket, just don't do anything. You'll end up paying more money out of pocket at the drugstore for no reason. We're both retired and we get our Medicare Part B and D through my husband's former employer and the state of Maryland. Okay, right. Now you got state coverage there too. Does this all apply, or should we be trusting? Stick with what you got. You've got nothing to worry about there, folks. I will go on Medicare in March of 2023. Do I have to wait until October for the Part D plans? No. You're going to be going, if you go on Medicare in March 2023, you do start your own initial enrollment period, and that includes Medicare Part D. I'm glad I should have said that earlier, but no, yeah, you can definitely sign up for Medicare Part D and should. And you can also sign up for your Medicare Part A and B in December. December is 3 months in advance. December, January, February. That's 3 months in advance of your birth month. So you could sign up to have it start on March 1. And when it comes to the prescription, you can sign up for the prescription drug plan 2 months in advance of your March 1 beginning. Who is Medicare advisor? Should we talk to them? Well, Medicare advisors would be somebody like me. I don't charge for my services. You know, if you want to get a Medicare supplement from me, great. That's how I get business. But if you want to just learn about it, just give me a call. Since there are many retired federal employees in this area, this may apply only to a good portion on this webinar. Question: my wife, therefore, and I have FEHB through her retirement benefit. Do we still need the Part B and G? No. Part B, yes. G, no. All right, well, those are the major questions that were there. Okay, I guess any other questions? I guess coming up, guys. Jeff, you there?
So yeah, I'm here. So now would be your time to get any last questions in to Mark, and those are all very helpful questions. I know that if you had a question, somebody else probably had the same question. So thank you very much. Looks like maybe one just came in. It looks like Mark said, I have Aetna with Medicare A and B coverage. Do you see that one, or is that a question that was already answered?
Yeah. He says he's got Aetna already, though. I don't know what he's got really, unless that's a drug program. Because he's got A and B, and I'm assuming that if he's got Aetna, then he could get a plan G if he wanted to through Aetna. You really should give me a call so I can identify what it is you really have, because you are eligible, from what I can tell, also to get a plan F. But Sometimes people get their Part Ds mixed up with A and B and supplements. So let's
Right.
kind of define what that really is that you've got.
Right. So, yeah, Mark, you did obviously a great job answering all those questions, and a lot of them are very specific questions that Mark can answer probably a little bit more succinctly offline. So feel free to give Mark a call. Again, a lot of his services are free, and your email again is mwtrent@verizon.net. Is that right, Mark?
Yes, sir. That's correct.
Okay, I've sent you so many emails. I've got it down by heart. So I'll be sure to send your contact information out through my post-webinar follow-up email that I send out through all of our webinars, and I'll make sure that's out no later than first thing tomorrow morning. And we appreciate you, Mark, for being here today and sharing all your knowledge as we enter the open enrollment season here for Medicare. And appreciate all our attendees being on today's webinar too. So as we enter the fall and everybody's back to school for our webinar series, coming up, we have next Wednesday a popular topic, what families need to know about planning for a loved one with special needs. That's with Mr. Stephen Elville. Also on Tuesday the 20th, staying mentally sharp. That's part 11 of our wellness series with Ms. Ellen Platt and Dr. Michelle Fritsch. Also on Wednesday the 21st, knowing the differences between assisted living facilities and skilled nursing facilities with our elder law attorney, Lindsay Moss. So that should round out the next couple weeks or so. And we have a very busy end of September and October as well for our webinar series. So we look forward to seeing you back again here soon, and appreciate you being here today again as well. So again, Mark, thank you very much again for a job well done as always. Look forward to having you back again sometime soon.
Thank you, Jeff. I appreciate it.
Okay, we'll see you again soon. Thanks for being here today.
You bet. Bye-bye.